Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. I'm Dr. Wanda Torres, and this is our serious conversations with our physicians. Um, Today, our guest is Dr. Ariana Tiberis. Welcome, Dr. Tiberi, to our conversation. So today's topic is abnormal uterine bleeding, which is I know is a broad topic. So I guess let's start with the definition. What is abnormal uterine bleeding?
Hey, I guess the easiest way to do that is start with what's normal, and then everything else tends to be abnormal. So typically, women bleed on a cycle of every 21 to 28 days, 21 to 35 days, and bleeding that's within 7 days is considered normal. So any bleeding that occurs between the cycle or between periods, any bleeding that is heavy, lasting more than 7 days, or typically we say filling a pad every hour. That's considered abnormal bleeding. Bleeding after menopause would be considered abnormal. Bleeding after intercourse is another form of bleeding that would be unusual. And then we have our patients that have less bleeding, but it's still considered abnormal bleeding, which would be skipping months of periods.
So when we do our history with the patients, we are, as you said, we're asking them how many pads they use per day. Um, do they bleed in between periods? Are they passing large blood clots? So the history is of utmost significance here. So as far as how are we going to work up our patients, how do we do that?
Right. So typically on the first visit, like you said, the most important thing is getting a good history. So we're going to ask you a lot of questions, as you know, that's why that helps us direct what we do next. But typically, yes, we get a lot of questions about your cycles, the days between them, how long are you bleeding, how much are you bleeding, how have your periods been before, when did you start having your first periods, when did you end menopause in the cases of postmenopausal bleeding. And then the second other thing that we do, the second most important thing that we do in that first visit is a physical exam. So, a physical exam gives us a lot of information. Bleeding can be a source through the vagina, it can be coming from the cervix, it can be coming from the uterus, it can be coming from issues with the cycle itself and hormonal disruption. So that exam is crucial in kind of pointing us in that initial direction. So taking a look at the cervix, making sure there's no polyps or signs of infection, making sure there's no signs of precancerous changes or cervical cancer, making sure there's not something simple as a vaginal laceration, which, is rare but can happen, with trauma or foreign objects. And then we do a bimanual, and we do all that through the speculum exam, which is the dreaded part of our gynecological exam, but definitely a very important part of our assessment. And then we do a bimanual, which allows us to kind of feel the size of the uterus. Is the uterus bigger than normal? Is that what's contributing to the bleeding? Is it irregular shaped? Are there potentially fibroids, which is a very common cause of bleeding? We feel the ovaries, make sure there's no tenderness or pain on exam.
Okay. So, so of course, we once we do the history and physical, we know where to guide this workup. So, I always tell my patients, I cannot forget about the thyroid. We need to talk about the thyroid and why it can cause abnormal bleeding. And then, of course, we will talk about all the different issues, polyps, etc. But tell me a little bit about the thyroid and why is that important?
Right. So the thyroid is a very important hormone gland that's located at the bottom of your neck. It controls a lot of the function in our body. It can disrupt mood. It can disrupt hormonal cycle, which feeds back to the same area of the brain and also controls the ovaries. It controls temperature regulation, hair, skin, organ function. And that is always, almost always part of the initial blood work that is sent is a thyroid studies if we have a suspicion that that might be what's going on to rule that out.
Mhm. So when we have the abnormal uterine bleeding and all of these possible etiologies or causes, one of the workups that we are going to do is to rule out for anemia. So besides checking for anemia, do you check for anything else? We mentioned the thyroid. Anything else that you're looking for?
Right, depending on kind of the presenting complaints, how the bleeding is, almost always we will include an ultrasound as part of the evaluation. That's another pivotal part of the workup that allows us to see the uterus, see the lining, look for any polyps, fibroids, look at how the ovaries may appear, and if someone is giving us an indication that they're having a lack of ovulation or skipping cycles, then we would direct the workup more towards hormonal labs and kind of to see if the ovaries, if you're ovulating.
So now, we discussed the thyroid, we discussed anemia. We get the ultrasound result, and we see multiple fibroids. How are you going to manage that patient?
Um, So, first I always explain to the patients the ultrasound finding. Fibroids are benign 99.9% of the time.
Mhm.
There are fibroids, fibroids don't suddenly change to cancerous process, but there is a very, very small percent that inherently can be of cancerous nature, but that is extremely rare. But most of the time, they are benign little balls of white muscle, and we don't know why it happens. We know that in up to 80% of women, they will have been told at some point that they have a finding of fibroids, no matter how small or big. And we do explain that there's a lot of ways to manage fibroids.
Mhm.
So, the location of the fibroids is super important. So, we can have someone who has a fibroid within the lining of the uterus and that is bleeding heavily. Those typically can be removed through the vagina because there won't be any type of medical treatment or kind of other surgical approach that would best be fitted for those type of fibroids. So we could remove them completely through the vagina and hopefully solve the bleeding.
So that would be a hysteroscopic myomectomy.
Exactly.
Um,
Mhm.
can that be done in the office? Can that be done in the hospital? How do we do that?
So typically, most of the time, those are reserved for the operating room. And the main reason is that they can bleed because they're very juicy. They
Mhm.
are supported by all of our hormones. So once we get to menopause, those fibroids stop getting their food and their hormones. So they kind of can shrivel a little bit, but for the most part, remain the same size. But yes, typically we do them in the operating room. If they're very small, we're suspecting that, um, they're either calcified or very tiny. It is something that we can potentially approach, in the clinic, but for the most part, we reserve those for the operating room.
Okay. Another procedure that we can discuss with the patients for treatment of fibroids is the uterine artery embolization, which is not performed by us, it's performed by the interventional radiologist. So, can you talk a little bit about that?
Right. So on talking about all the options of treating abnormal
Right.
bleeding, yes, that is one that we mention to our patients and we discuss with them. It is a minimally invasive procedure. It has a certain type of patient that it's best for. Involves a catheter going through one of the arteries in the leg typically, but they can also go through the arm, where they inject kind of like this substance. It's not a medicine. I always
Mhm.
describe to the patients that it's just a substance. They're little tiny beads that kind of block the blood flow to the uterus. So they block off the uterine artery. With that, the uterus and the fibroids lose their support. They lose their food essentially, and the uterus can kind of shrink. The bleeding can stop, and it can, significantly help with their symptoms. There is, and I think it's quoted in the range of 60 to 80% success
Mhm.
rate, but there are obviously a percentage of patients that go on to require further management.
Correct. So, we have talked a little bit about the surgical management of fibroids. We have talked about myomectomies, hysteroscopic myomectomies, laparoscopic myomectomies, uterine artery embolization, and hysterectomy. But there's medical management. So, how can we help the patients with abnormal uterine bleeding secondary to fibroids?
Right. So, kind of all, fibroids goes along hand in hand with also
Mhm.
endometriosis and adenomyosis. So I will just put them all together because they are cousin conditions, but the medical treatments are kind of the same, directed at all of them. One of them, least invasive, we can typically offer a course of birth control or combined pills, which will kind of stop our ovaries from doing its job, stop our body from having its cycle, and so we're providing our body with those hormones. That can decrease blood loss, it can help regulate the cycle, and it can also help with the pain aspect of fibroids, adenomyosis, and endometriosis. Another option that we're liking more and more is use of the hormonal IUD.
Mhm.
That is approved for use with fibroids. It can help with endometriosis and adenomyosis, all of which can cause heavy bleeding,
Mhm.
painful periods, and that's something can be used for up to 5 years.
Another way to manage abnormal uterine bleeding is with NSAIDs
Mhm.
and the tranexamic acid. So, can you explain to the patients how those work and how do we use them?
Right. So, non-steroidal anti-inflammatory medications, otherwise known to everyone as kind of ibuprofen, Advil, Aleve, and Motrin, work by basically blocking an inflammatory response in the uterus that tends to cause pain. So, um, it is typically first line, usually one of the first things we go to when we tell patients that they should be using NSAIDs as kind of the first step to manage pain with and heavy bleeding.
Mhm.
Especially in those younger adolescents who have kind of a dysregulated cycle, before jumping on birth control pills, it typically is something that we would try
The
first.
first line.
Yeah.
Yeah.
And as far as tranexamic acid or TXA, that has been recently kind of explored as a very good way to manage heavy bleeding. It was initially used in trauma and orthopedic kind of surgeries with heavy bleeding, and then we explored it in the context of abnormal uterine bleeding, especially for the patients that come to the hospital with need for blood transfusion or actively bleeding and need something pretty quick to stop
Mhm.
the bleeding. And that has, in its as a super positive side of it, it has translated to outpatient use of it. So there is a regimen for really heavy bleeding that starts where you take the tranexamic acid, which is a pill, 3 times a day
Mhm.
for up to 5 days, and that should help with stopping bleeding.
Okay. Well, fantastic. So, again, this is a very, very broad topic. So, we mentioned how we manage abnormal bleeding for fibroids, endometriosis, and adenomyosis. But now we need to go into the polyps, uterine polyps. So, how do we manage those? How we diagnose them?
Right. So polyps, I would say, are probably one of the most common causes of abnormal bleeding and can cause bleeding after sex, bleeding between cycles, predominantly, and also can cause heavy cycles. So typically, if someone's coming with abnormal bleeding, part of the workup is ultrasound. If we suspect a polyp based on the pictures and how it looks, your lining could be thickened or they could actually see a polyp
Mhm.
in there. And we do recommend removal of the polyp.
Mhm.
And so the ways that we do that typically is through hysteroscopy, where we insert your camera in through the vagina and we inject water kind of into the uterus so it blows up again like a little balloon, and we're able to visualize the polyp and we remove it directly under vision.
And the vast majority of polyps are benign, but they
Mhm.
have a small percentage. I always remind the patients there's a small percentage that
Yes,
they could be precancerous or cancerous. So we always need to evaluate them, remove them, and send them to pathology.
definitely.
So another cause of abnormal uterine bleeding are the hyperplasias, endometrial hyperplasias. So tell us about them.
Right. So anytime any patient comes to our office and complains of abnormal bleeding, we always have to consider the possibility that this is potentially a precancerous overgrowth of the lining or even, endometrial carcinoma. Um, there are a lot of risk factors that were well known, as far as causing endometrial cancer or hyperplasia. Most common one is obesity. And that is a big player in the fact that is a big player in one of the causes to endometrial hyperplasia. And the reason behind that, and I always like to explain to my patients so they understand, is that when women all predominantly have a large proportion of adipose tissue, especially more than men. And so that adipose tissue actually produces estrogen. It's a form of estrogen that's produced from our adipose tissue. So when women have a higher percentage of fat tissue, they have a higher percentage of estrogen that's being produced from those fat cells, and that creates kind of an imbalance in the hormonal environment. And so it can create too much estrogen, not enough progesterone to kind of match up. And so we get an overstimulation or too much estrogen going to the lining. Progesterone is known as our endometrial protector. So that's why we like to talk about things like medical treatment, involving progesterone. So progesterone IUD, a progesterone implant, Depo-Provera, the injection, um, and progesterone pills.
Okay.
Yeah.
So if we have a patient with endometrial hyperplasia, there's different types of hyperplasia. So not everyone ends with a hysterectomy. So as you mentioned, we are going to offer the patients the progestins, the Mirena IUDs, etc. But if we have a patient with complex endometrial hyperplasia, which has another name, what do we do for them?
Right. So it depends on the age of your
Yeah.
patient and kind of their fertility goals. But
Yes.
in general, the first line and recommended treatment for complex hyperplasia are basically an overgrowth of the lining that has gone a little bit haywire but isn't yet at the stage of cancer. We recommend hysterectomy as the first line. If the fertility goals have been completed or achieved, and they're not planning on future fertility, that would be the first recommendation. Of course, if there are plans for fertility, and they haven't yet completed their family goals, then the next step would be to consider something like progesterone therapy. So either, typically progestin only pill or direct suppression with that progesterone IUD implanted directly at the source of the problem.
Okay. And in other conversations and podcasts, we have discussed polycystic ovaries. So we're not going to go in depth into that, but we can mention a little bit about PCOS can cause abnormal bleeding. So go ahead and tell us a little bit about that.
Right.
Not in depth, but can cut that.
So has So yeah, PCOS is definitely a very common cause of abnormal bleeding. Typically, we see the patients come in with irregular cycles. So the cycles can be, ranging from 15 days, 45 days to 80 days to skipping kind of several months at a time or not having any bleeding at all. And that's abnormal, and so we need to do something about it. Typically, what that involves, and I came up with a really funny analogy for my patients, but they said they like it, so and it makes sense to them. So PCOS is kind of like a bunch of chickens that are stuck in a cage, and that's all the eggs of the ovaries.
I love this analogy. I'm going to use it
No,
myself.
it's great. Listen, so they have, there's all these chickens that are stuck in the cage and they're all trying to grow and get fed and be the biggest one so that they can be released from the cage, not killed, but released from the released from the cage and kind of set free. And that's kind of the analogy to ovulation. So in a typical normal ovary, every cycle, one ovary follicle gets to grow bigger than the others and is the one that gets ovulated. All the others, which I think is about in the range of 10,000 follicles each cycle, kind of get disregarded, like they atrophy and disappear. In PCOS, they're all kind of getting enlarged, they're all getting stimulated, and that's because of the hormonal imbalance. And so, not one of the chickens gets to be big enough to leave, so they all just stay kind of mildly big. And then we don't get a big surge of a certain hormone that allows that egg to be released. And that's how we get to PCOS. And so, these women typically have anovulatory cycles or they're not ovulating. They can also have, symptoms of too many male hormones or a predominant male hormone that we call the androgens in our body, which can contribute to abnormal facial hair growth, acne, and what we call signs of hirsutism.
So we manage this patient's first line of treatment. If they're not looking into conceiving, we offer contraceptives, or if they desire to conceive them, we go with the progestins. So let's move on a little bit because I want to touch into doing hysteroscopies, DNCs with endometrial ablations, hysteroscopy DNC by itself, or adding an endometrial ablation. So, can you explain to the patients what this is and how do we do it?
Right. So, if we've realized that none of the other causes of abnormal bleeding fit the picture, and we're just dealing with a woman who has really heavy periods and she wants to do something about it, his diagnostic hysteroscopy can be an option to kind of go in, take a surveillance of the cavity, take a really good biopsy, which is called the curettage part of the procedure, and send it just to make sure we're not, missing any other source of bleeding. And then they have the option if they're considering, proceeding with an ablation. It can be done at the same time. And an ablation involves basically burning the inside lining. It doesn't burn your uterus, it just burns the inside lining. And that's done in a very similar fashion as far as procedure goes, where we go in with a camera, we insert some water, we take a look, we take some measurements, and then we introduce a device that does a burning cycle of about 30 to 90 seconds typically.
Okay. And it has a pretty high success rate. There's a percentage of patients that won't have any periods at all after that ablation. And we have done them in the office
Mhm.
with the nitrous oxide, and the patients have tolerated them very well.
Yeah.
Okay. So, anything else that you want to tell us about abnormal uterine bleeding?
I guess the other big common cause of bleeding would be in the perimenopausal stage, which we're realizing more and more that is a super important part of a woman's life, and the bleeding can become heavier. The bleeding can become, it can skip months. It can become, closer together. Once we've done kind of ruling out all the other causes, and we're just suspecting that this is a perimenopausal dysregulation of the hormones. Typically we can counsel them on the options, again, medical treatment. So something like a pill, low dose estrogen, progesterone pill, or a progestin pill that they can kind of take, especially if they're having other kind of early perimenopausal symptoms like hot flashes, mood changes. Some patients develop more stronger PMS symptoms around perimenopause. So they always say, I feel like I'm back in my adolescent teenager years, and that's common, and so those kind of medical treatments can help manage those initial symptoms, and then, stopping the bleeding altogether, hopefully with, something like a hormonal
Mm,
IUD.
yeah. Thank you, Dr. Tiberi, for all that knowledge and sharing your knowledge and the wealth of information that you have given us about abnormal uterine bleeding.
Oh, thank you so much for having me. It was a pleasure. Oh.
Well, great. That is a wrap.